Prosthetic joint infection case discussion. A 60-year-old male patient with a history of hip replacement 4 weeks ago presents with sudden onset of pain, swelling, and redness around the surgical site. He reports mild fever, and the wound appears to be draining. Laboratory findings show elevated CRP and ESR. Possible VIVA questions. What is the likely diagnosis in this case? The answer is acute prosthetic joint infection. The sudden onset of symptoms, pain, swelling, fever, and drainage, and the timing, 4 weeks post-surgery, suggest an acute infection. How would you diagnose this condition? The answer is, diagnosis is confirmed by joint aspiration, where synovial fluid analysis for elevated white blood cell, WBC, count and polymorphonuclear cells, PMNs, will help. Microbiological cultures of the fluid will identify the causative pathogen. Aspiration is critical to confirm the infection and identify the pathogen. What are the common pathogens for prosthetic joint infections? The answer is Staphylococcus aureus, Staphylococcus epidermidis, and coagulase-negative staphylococci. These are the most common pathogens associated with PJI, especially in the early stages. Prosthetic joint infection case discussion. A 50-year-old female patient presents 6 months after knee replacement surgery with persistent pain and gradual swelling around the joint. She has a history of rheumatoid arthritis and has been on methotrexate therapy. A radiograph shows implant loosening, and joint aspiration reveals a high WBC count with a positive culture for Staphylococcus epidermidis. Possible VIVA questions. What is the most likely cause of this patient's symptoms? The answer is chronic prosthetic joint infection due to biofilm formation. The infection has been present for months, and the pathogen is likely forming a biofilm on the prosthesis, which leads to persistent symptoms and difficulty in treatment. What is the significance of biofilm in prosthetic joint infections? The answer is, biofilm protects bacteria from the host immune response and makes eradication difficult. It also reduces the effectiveness of antibiotics. Biofilm formation is a key factor in chronic infection, making it harder to treat with antibiotics alone. What would be the management strategy for this patient? The answer is, 2-stage revision arthroplasty is the gold standard for treating chronic infections. This approach allows for the removal of the infected prosthesis, followed by a period of antibiotic therapy and then reimplantation. Prosthetic joint infection case discussion. A 70-year-old diabetic male presents with hip pain 8 weeks after total hip replacement. He has poorly controlled diabetes, HbA1c greater than 8. On examination, the joint is swollen, warm, and tender. Laboratory findings show elevated CRP, ESR, and WBC count. Radiographs show early signs of loosening. Possible VIVA questions. How does diabetes mellitus contribute to the risk of prosthetic joint infection? The answer is, poorly controlled diabetes leads to immune dysfunction, impaired wound healing, and increased susceptibility to infections. High blood glucose levels impair neutrophil function and reduce the ability to fight off infections, increasing the risk of PJI. What is the role of CRP and ESR in the diagnosis? The answer is, CRP and ESR are inflammatory markers that are often elevated in PJI, helping to support the diagnosis when combined with clinical findings. Both markers are nonspecific but are commonly used to track the inflammation associated with infection. What surgical approach would you recommend in this case? The answer is, 1-stage revision arthroplasty could be considered for patients who are not suitable for 2-stage procedures. Given the chronicity of the infection, 8 weeks post-surgery, and the patient's medical condition, a 1-stage revision may be appropriate. Prosthetic joint infection case discussion. A 45-year-old male with a history of knee replacement presents with knee pain and swelling 10 weeks after dental extraction. He recently had dental work and was not given prophylactic antibiotics. He now presents with signs of infection around the knee joint, with elevated CRP and ESR. Possible VIVA questions. What is the likely source of the infection in this case? The answer is, hematogenous spread from dental work. Dental procedures can introduce bacteria into the bloodstream, which can seed the prosthetic joint, causing infection. How would you confirm the diagnosis? The answer is, joint aspiration and microbiological cultures of the fluid are necessary to confirm the diagnosis and identify the pathogen. Aspiration provides direct evidence of infection by isolating the pathogen from the joint fluid. What preventive measure could have been taken before dental work? The answer is prophylactic antibiotics prior to dental procedures to reduce the risk of hematogenous spread. Patients with prosthetic joints are at higher risk of infection from bacteremia caused by dental procedures. Prosthetic joint infection case discussion. A 55-year-old female with a history of renal transplant and immunosuppressive therapy presents with knee pain and swelling 5 weeks after knee arthroplasty. She is on immunosuppressive drugs, including anti-TNF agents. Joint aspiration reveals a high WBC count, and cultures grows Staphylococcus aureus. Possible VIVA questions. How does immunosuppression increase the risk of prosthetic joint infection? The answer is, immunosuppressive medications, such as anti-TNF agents, reduce the body's ability to mount an effective immune response, increasing susceptibility to infections. These drugs inhibit the body's inflammatory response, making it harder to fight infections. What is the first-line treatment for this patient's infection? The answer is, the first-line treatment would involve surgical debridement and appropriate antibiotics based on the culture results. In this case, Staphylococcus aureus may require extended antibiotic therapy. Surgical intervention to remove infected tissue and a tailored antibiotic regimen are necessary for treating PJI in immunocompromised patients. What would be the long-term management strategy for this patient? The answer is, long-term suppressive antibiotic therapy may be needed for immunocompromised patients who cannot undergo complete surgical revision. Immunocompromised patients may have difficulty clearing infections, and chronic antibiotic therapy helps control the infection while avoiding surgery if possible.